Good afternoon, everyone. Thank you so much for joining us for this webinar that's part of the Emmy project, Elevating the Medicaid Enrollment Experience. My name is Jen Wagner, and I am the Director of Medicaid Eligibility and Enrollment at the Center on Budget and Policy Priorities. I am pleased to be joined here by two colleagues from CBPP, as well as Suzanne Weichel from the Center for Law and Social Policy. Today, we're going to talk about how to frame some of the administrative barriers that people see in Medicaid in terms of racial equity and health equity. Now, we're going to still talk about the nitty-gritty access and streamlining issues that we usually talk about as part of these webinars and as part of Emmy, but we're going to think of them in a little different framing today. We're going to think about how they put up barriers to racial equity and health equity, whether they're done intentionally by the state or inadvertently. And this is an important context and a possibly important framing in your state as we look ahead to unwinding the Medicaid continuous coverage requirement. During that period, during the unwinding and beyond, a lot of these administrative burdens are going to be even more prominent than usual. With decreased state capacity and backlogs and things like this, the administrative burden is going to be greater and more harmful than usual. And especially in light of some new research that shows how this burden falls more dramatically disproportionately than we even realized on people of color. It's really important to tackle these administrative burdens, and we're hoping to provide a little different kind of framing for discussing these burdens going forward. So please submit any questions you have using the Q&A function in the Zoom. And also, we know that a lot of you have been thinking about this in your state, both the administrative burdens and the racial equity angle. And we'd love to hear from you about what you've experienced, what you've learned. So feel free to submit any comments or ideas or experiences that you've had as well in the Q&A function. We'd love to hear that. And then we will have time at the end for any questions. So with that, I'm pleased to turn it over to my colleague, Farah.
Awesome. Thanks so much, Jen. Sorry, just figuring out these technical Zoom things. Let's see. Great. Okay. So yeah, for today's agenda, we're going to be talking about administrative burdens through an equity lens. So first touching on definitions and history of administrative burdens and contextualizing them through the Medicaid program, administrative burdens described by people with lived experience, the context of today and why this is so important in 2023, and lastly, some policy and advocacy approaches to reduce administrative burdens. So let's start with what are administrative burdens. So generally speaking, administrative burdens are the onerous experiences that individuals face when navigating a system or a program. And in this case, we're focusing on Medicaid. This is often referred to as red tape, the aspects of navigating the program that make it difficult to access services and stay covered. And there are really three types of administrative burdens within the Medicaid context that we talk about that are really characterized by the work of Pamela Hurd and Donald Moynihan in their foundational work on administrative burdens. And so the main one we're going to be focusing on today are compliance costs. So this includes the time that people spend having to comply with the requirements of the program, whether that's completing forms for an application or a renewal, the time people spend waiting for help, the time and energy it takes to collect information and documents, and other onerous steps that are required to access and keep access to coverage. There are also learning costs involved with accessing and navigating the Medicaid program. So this is, the burden of a steep learning curve that people experience in order to access the program. These programs are very complex and confusing to many people, including applicants and enrollees, and for them to understand, it's very difficult. So enrollees are often burdened by the need to gather information about the program, figure out if they're eligible, learn how to apply, and then navigate systems like finding out what services are covered and finding providers. And lastly, we have psychological costs that are really sort of the stresses that people experience in navigating the process that can look like stigma and negative treatment by the state agency, but also sort of the overall mental strain that people experience by having to take so many steps to prove that they're eligible and worthy of receiving support. We also wanted to contextualize the conversation by sort of providing some definitions on the different types of racism that we talk about throughout the paper that we released in the presentation, and also terms related to equity. So within the context of systemic racism, there are two types that we really focus on here. The first being institutional racism. So thinking about this is really the racism that occurs within institutions. So within this context, thinking about the racism that's really baked into the Medicaid program. So the way that the policies and practices of the program sort of cause and exacerbate inequitable outcomes for people of color on the basis of their race and better outcomes for white people. Structural racism is the racism that occurs sort of across institutions. So really thinking about how racism operates as a system of power with multiple interconnected components that reinforce each other and result in racial inequities across the board rather than just in one particular institution. So it's the racial inequity that's deeply rooted and embedded in our historical and culture and economic and political and legal systems. So I'm sure many people have seen this image before, but I think it does a really great job of highlighting what equity really is and what we mean when we talk about it today. So equity, as you can see in sort of the third column there, is really about ensuring that the outcomes and conditions of the well-being of folks are improved for marginalized groups. So understanding that various groups have unique needs based on their histories of marginalization. The ultimate goal when addressing equity is achieving justice, where everyone can thrive without systemic barriers in the way. And when thinking about racial equity specifically, this is the process of eliminating those inequities that are rooted in racism and improving outcomes for everyone, including people of color. So it's sort of this intentional and continuous practice of changing policies, practices, systems, and structures by prioritizing measurable change in the lives of people of color. So contextualizing all of this within the Medicaid program, what do administrative burdens look like in Medicaid? So the burdens take shape in many forms, and I'll run through a few examples here. The first being sort of this overarching theme of paperwork barriers. So this can look like agencies relying on paper documents rather than electronic data sources when they're available, but also sort of the trend of long and complex forms that people have to fill out, and also the long and complex notices that people get in the mail that are oftentimes confusing and complex and use really technical language that is not accessible to the average reading level. These burdens really delay access to care for people who need it and are often just unnecessary if the state has reliable electronic information already or the ability to modify forms and notices to make them more user-friendly. Also, we know in today's world that people use the internet and their smartphones for practically everything. So despite technological advances in some areas, lots of state Medicaid agencies still don't have applications that are online that are human-centered and user-friendly, and often are not mobile-friendly either. So these barriers really decrease the modalities that people have at their disposal to be able to access Medicaid. So, and long wait times are also a significant barrier that people experience when trying to navigate the program. People with low incomes might have limited minutes on cell phones and can't afford to stay on hold for long periods of time. And for those who want to meet in person with an eligibility worker, they might not be able to take the time off of work to account for long wait times or limited office hours. Immigrants are also subject to navigating a very confusing web of eligibility criteria, including Medicaid and other benefits programs, which impose barriers to coverage on the basis of their eligibility, but also administratively. And immigrants and applicants and enrollees whose first language is not English face additional language access barriers when important information or enrollment assistance is not available in someone's preferred language. We also know that Medicaid programs often rely on snail mail to communicate with applicants and enrollees, but many low-income families with Medicaid experience housing instability and might lack access to a reliable mailbox. So folks who don't receive mail from the agency requiring them to submit documents or renewal forms often lose coverage, even though they're still eligible, and often have to restart the application process. And lastly, there's periodic data checks that are really burdensome in Medicaid. So 30 states at this point check electronic data sources periodically in an enrollee's 12-month enrollment period to identify changes in income or other circumstances. And oftentimes there are folks who receive these requests that have maybe picked up an extra shift or switched employers or experienced other changes that don't actually affect their eligibility, but folks might still lose coverage because they don't receive the notice or don't understand what type of action is required or can't provide the information requested within the right time frame. So at this point, I'm going to turn it over to Suzanne.
Hi, thanks, Farah, and hello to everyone who's watching. So as far as described administrative burdens, just to recap, essentially they make it harder to keep coverage and they make it harder to apply for coverage and keep coverage. And we're particularly talking about people who are eligible and have trouble accessing the programs for which they are eligible. And we know that they don't affect everyone the same way. And it's summed up really clearly in this quote from the OMB office. Administrative burden exacerbates inequity. And they go on in this quote to say, because these burdens do not fall equally on all entities and individuals, leading to disproportionate underutilization of critical services and programs, as well as unequal costs of access, often by the people and communities that need them the most. So when we think about why, and I put some statistics up there about Medicaid enrollment, that it's majority people of color, and that is very different from employer-sponsored insurance and Medicare. I think it's important to talk a little bit more about the systems of racism that lead us to this, and then digging into a little bit more of the history of Medicaid. Next slide, please. So we know, and this is all summed up in the paper that was released that this webinar is based on, that systemic racism across our communities, across all systems in our society, particularly education, employment, housing, and transportation, ultimately causes people of color to have lower incomes, which leads to not having as much access to employer coverage. So specifically, some of the results of this racism are, and if you can go to the next slide, please. Workers who are Black or Latino have higher rates of part-time employment than white workers, and 77% of part-time workers don't have access to employer coverage. So we know, especially in states that have Medicaid expansion, they are more likely to be eligible for Medicaid, and that's where they're turning for their health insurance. And then another statistic that from 2018, that just over half of Black workers had private health insurance compared to nearly 3/4 of white workers. So I think when we think about this and we think about the racism and the systemic racism that has led to these, I think one of the things we have to think about in terms of administrative burdens and Medicaid is, what is the history of Medicaid? How did it kind of evolve? How did it come about? And how has that changed over time to reflect some of the burdens that we see today? So I'll dig into a little bit of the history. Next slide, please. So back when Medicaid was first created, it was initially tied to cash assistance for families, aid to families with dependent children, which is now not the name of the cash assistance program. But initially, this is important to understand that Medicaid was tied to this. And that AFDC really had embedded in it this idea of, some people are deserving of assistance and some people are not deserving. And this concept of deserving is something that we'll come back to in a minute. And not surprisingly, it was often white mothers, white children that were deemed more deserving, and policies were put in place to stigmatize or make it harder for Black families to access cash assistance. So specifically, many states with AFDC implemented what was called morals-based eligibility requirements that specifically targeted Black and unmarried mothers. So for example, some state policies included things called like suitable home requirements that denied benefits if there was any sign of, quote, a man in the house. This could be something as simple as an extra toothbrush or a large pair of shoes. These rules were applied very subjectively and often unequally to Black mothers and their children. Some states halted AFDC benefits during planting and harvesting seasons to coerce Black parents to work in agricultural jobs. And states set their own benefit levels and income eligibility limits. And not surprisingly, states with large Black populations, mostly in the South, typically set lower benefit amounts and eligibility levels. And here's the key to this from the Medicaid context. Because Medicaid eligibility was linked to AFDC, these racist policies in AFDC and this whole idea and concept that some are deserving and some are not were applied to Medicaid when it was first created. Okay, so we will fast forward a little bit. to the PRORA in 1996, which is often referred to as the welfare reform legislation. So this delinked Medicaid from AFDC. It also kind of eliminated AFDC and created the TANF program that we have now in terms of cash assistance. But relics of the AFDC program remain. So for example, minimum Medicaid income eligibility thresholds for parents and caretaker relatives were still based on AFDC eligibility thresholds, which, as we said, varied greatly by state. Applicants subject to asset tests and interview requirements continued to face those barriers to enrollment. And importantly, the PRORA introduced the 5-year bar for certain immigrants in Medicaid. And this really has added a lot of administrative barriers and eligibility complications for immigrant populations. And again, all of this that still remained under PRORA still reflected this concept that people have to prove their eligibility, right? They have to prove that they're deserving of the program. Fast forwarding a little bit further to the Affordable Care Act, which made great strides overall in reducing administrative burden. So one, Medicaid expansion kind of in theory took out much of the concept of who is deserving. But of course, we know with the SCOTUS decision that made Medicaid expansion optional, obviously the debate around who is deserving continues, particularly in are now 11 non-expansion states. I'm happy to report I had 12 in my notes, but after the results in South Dakota yesterday, I'm going to start saying 11. So examples of the ACA that really did make significant progress reducing administrative burdens, including prohibiting in-person interviews, requiring multiple methods of application and renewal, in-person, mail, online, and telephonic, elimination of asset tests and the paperwork verifications that go along with that. And I really want to be clear, we're being specific to the MAGI population here. And then the requirement of ex parte renewals, which are in theory completely handled by the state, and an enrollee doesn't have to complete paperwork. And I want to say that although the ACA has made great strides, and that's undisputable, we know, and particularly we know from our work with many of the advocates who are on this call, that in reality, administrative burdens look different across states. And some states have much greater burdens than others, and some states have really taken the spirit of the ACA a little bit further than other states have as well. And so I'm going to turn it back over to Farah, who's going to share some examples of administrative burdens experienced by people who are insured by Medicaid.
Awesome. Thank you so much, Suzanne. So yeah, we wanted to kind of put some color to the things that we're talking about by highlighting some examples of how people with lived experience describe the administrative burdens that they endure. And so this information is all findings from our partner reports that are, a few organizations across the country that we work with on a project that's called Emmy Voices. That's really focused on highlighting the voices of people with lived experience and their experiences navigating the Medicaid enrollment and renewal process. So first, we have a few quotes from the Immigration Research Initiative based in New York, who really has focused on gathering the voices of people with lived experience in the immigrant community. So we have a quote here from Vanessa in New York City, who says, "They don't have translators. I speak a little English, but the people in the office didn't understand me. It's a little difficult to complete the process and it takes a long time. If there's not an interpreter, you won't be able to get what you need done that day. You'll have to come back another day. Calls take too long." So this is really talking about sort of the compliance costs. We're talking about the waiting game that people have to play and sort of how that delays access to coverage and might oftentimes actually deter people from completing the application process in the first place. We also have a quote from Lucia that says, "Think about it. You're leaving behind your family, your food, your culture, and your past, and you carry on with this backpack trying to adjust and be part of something that you don't even know, and it's uncertain. And people tend to not even have spaces to put their paperwork. And I remember myself living in boxes every time I needed to move. And one year I moved 10 times for different reasons. It was so unstable. That was so hard to keep things in order, but however I did. And I think that's because if you have your picture ID, your birth certificate, and have all your papers in one place, at least you'll be able to provide it when they need it to apply for these programs." So this sort of really speaks to the onerous requirement for folks to have all sorts of paperwork ready And folks from marginalized backgrounds and immigrant communities often really struggle to be able to keep track of and produce these documents, especially over long periods of time. So just really putting some color to the paperwork barriers that people experience. We also wanted to highlight some findings from our partners in Mississippi at the Mississippi Center for Justice. So in the draft report of their Emmy Voices project, they found some really striking findings. So half of the people that they spoke to waited over 30 days after applying to hear about the status of their Medicaid application. They also heard that about 70% of folks had to speak to a representative at some point in the enrollment process, which I think is really striking, especially because in-person interviews are prohibited for Magi folks in the program. Just the fact that so many people have had to speak with a Medicaid representative in order to successfully complete the process is very striking. And then a fourth of folks that applied for Medicaid that they spoke to applied online, but it's important to note that Mississippi does not have an online renewal option. And so that can really affect people's ability to maintain their coverage if, using an online application as their preferred method of applying, but not being able to renew, that might impede their ability to keep coverage. And it's also important to note that 1/4 of the folks that they spoke to actually don't have direct access to internet. And so the lack of an online renewal process goes directly to the retention of beneficiaries. And lastly, we have some findings from the West Virginia Center on Budget and Policy. So 1/2 of the people that they spoke to in West Virginia experienced difficulty reaching the Medicaid agency over the phone. And we sort of talked about this earlier, but just the difficulty of people being able to stay on the phone all day and sort of wait for a representative to answer the phone is really burdensome and onerous for folks. And again, might just, result in, people falling off and not being able to complete the process. They also reported that about 1/4 of folks that they spoke to face barriers submitting paperwork and documentation. And lastly, about 2/3 of the folks that they spoke to said the distance to their local DHHR office was a barrier because of the transportation issues that people might experience, or just the sheer distance between where someone lives and where the nearest office might present another challenge when they're trying to talk to somebody about their coverage, might need additional support, or might need to provide documentation in order to complete their application or renewal. So with that, I'm going to turn it back over to Suzanne, I believe.
Okay, great. Thank you for those examples, Farah. So, we here at the Emmy Project believe that reducing administrative burdens is always important. It's what we talk about all the time. It's what we work on with state advocates regularly, routinely, and we believe there's always room for improvement. As I'm sure many of you are aware, the stakes are particularly high in 2023, and we believe that doing everything we can to continue reducing administrative burdens is especially important in 2023. Farah, can you move to the next slide, please? So just a little bit of context for those of you who may not be as up to speed with us as we are that talk about this every day, but sometime in 2023, we do expect the end of the COVID-related continuous coverage provision. So this has been in place since March of 2020, that somebody who is enrolled in Medicaid has not been able to be disenrolled unless they have asked to or they have moved out of state. And so what this has resulted in is that there are record enrollments in Medicaid across the country. And it has also resulted in the elimination of a lot of administrative burden, right? Because people haven't had to complete the renewal process, although many people have completed the renewal process from their state. For those who were unable to complete the process, there has not been a loss of coverage as a result of that. When the continuous coverage provision ends, we know that states will be tasked with a very large undertaking. They will have to renew everybody who is enrolled in Medicaid. And we know that renewals are a very high risk time, that when administrative burdens present challenges and often lead to disenrollment. As a result of this, I think we all have seen some of the estimates that we do expect significant coverage losses in Medicaid enrollment in 2023 with disparate impacts, which we will get to briefly. And I do want to pause and say, some of the coverage losses we will see are expected because people are no longer eligible, and they should transition to marketplace coverage, or unfortunately, those in the non-expansion states, many will fall into the coverage gap. But we also know that many who will lose coverage are still eligible. And it's really these administrative burdens that we're talking about that's preventing them from retaining that coverage. So just to be clear, estimates are showing about 15 million people are expected to lose coverage. And of that 15 million, about 6.8 are estimated to still be eligible. So we're talking about potentially 6.8 million people losing coverage due to administrative burdens, and not to the fact that they have lost eligibility. So although we are nearing the end of 2022 and we do not know, a date when the continuous coverage provision will end, we really want to emphasize that there is still time for states to act to reduce administrative burdens and mitigate the coverage loss that is expected. Next slide, please, Brian. So this is a slide from a report that Stan Dorn put out with Unidos US that just shows by race and ethnicity the coverage losses that are expected among children. So just to be clear, this is among children. You can note that children of color are more children of color proportionally are going to lose coverage than white children. This is in part due to just the reflection of Medicaid enrollment by race and ethnicity, but I think it's important to remember when we think about who is at risk of losing coverage in 2023 when the continuous coverage provision ends, children of color, people of color are at greater risk. Next slide, please. And then this is a chart from ASPE, which is a research arm of HHS that hones in a little bit more on the impact of administrative burdens after the end of the continuous coverage provision. As you can see on this, losses in Medicaid among white enrollees are much more likely to be due to loss of Medicaid eligibility and much less likely to be due to administrative churning, or as we like to talk about it in terms of the administrative burdens being the reason that many people are likely to not renew their coverage and lose that coverage, at least temporarily. You can see here that all populations of color are much more likely to have churning or that administrative coverage loss than the white Medicaid enrollees. So we've set the stage in terms of what administrative burdens are, what's at stake in 2023. And I'm going to hand it over to Jenny to dive more into the policy and advocacy approaches.
Okay, great. Thank you. So as if you didn't already have unwinding at the top of your mind, now you've got even more data to back up just how much is at stake next year, and particularly for people of color. So before we move to Q&A, and we do encourage you to submit your questions via Q&A at any time, but before we move to our active Q&A session, let's talk more about what you can do to mitigate some of this harm. Next slide. So this is the policy playbook, and I decided not to date myself and just put up a movie poster from the 90s from The Usual Suspects, but that's what comes to mind when I see these concepts. These are strategies you likely know really well, and hopefully your state has implemented at least some of them or started in the right direction on some of them, but there's never been a more important time to advocate that your state do more. So improvements in these 4 areas we think will do the most to reduce administrative burdens on Medicaid enrollees during unwinding. So let's talk a little bit more about each one. The first, of course, is 12-month continuous eligibility, which means that once someone is approved and enrolled, they're guaranteed coverage for 12 months, even if they have income fluctuations. We talked about this earlier in the presentation, but for example, if someone picks up extra seasonal shifts or gets overtime during a busy time at work, their Medicaid eligibility is not at risk. And this would extend some of the protections that, of course, people have been enjoying during the public health emergency and the continuous coverage requirements that have been in place then. And right now, 32 states provide 12-month continuous for kids, but it's far less common for the adult MAGI population. Only 4 states provide it right now for adults, so some work to do there. Next, reducing verification requests, and this is really at the core of reducing administrative burden. Simply put, when we reduce the amount of paperwork people have to send to the state, we reduce the chance that their coverage will lapse or be terminated. There's a few key ways to do this, and lots of papers available on the ME project website to dig into these deeper if you are so inclined, and we hope you are. But the first is to increase ex parte renewals. These are renewals that the state conducts based on info they already have access to, like wage data. And the Medicaid enrollee then doesn't have to fill anything out or send anything back if the state can get the information it needs from existing databases. And states vary widely in how well they do with ex parte renewals, but in many states, maybe most states, there's significant room for improvement. There are 9 states that have ex parte renewal rates of 75% or higher. And these are not states that often are grouped together for other kinds of analyses. It's everything from Alabama and Arkansas to Idaho, North Carolina, Ohio, Rhode Island. These are not states that you see as high performers in other aspects of access and eligibility. So just to note that it is possible in lots of different places. The next, or sort of a second part of reducing verification, is eliminating or modifying periodic data matches. Some states choose to do quarterly or semi-annual checks with income databases, and then if they detect a discrepancy, they send a notice to the Medicaid enrollee asking for more information or documentation. And if they don't hear back, then the person can lose coverage. These are not something that need to happen as often as they do, and states can significantly roll these back. The third thing in our list is really accessible online services. States are required to allow people to apply and renew online. That has been true since the Affordable Care Act was enacted, or since 2014. But we know that in practice, this looks really different from one state to the next. So making online services accessible means that the website is mobile friendly, meaning it works well on a mobile phone or tablet. And this is particularly important since a growing number of low-income people have access to a mobile phone or a tablet, but not to a desktop computer or broadband internet at home. And only about 20 states have websites with mobile-friendly designs, so plenty of room for growth there. The process to set up an account and do identity proofing should also not be overly complicated. We know that this trips people up regularly. And the actual application should be easy to navigate and understand. One example where a state recently made some changes was in New Mexico. They eliminated some confusing language that was requesting social security numbers from non-applicants, which is not necessary. And that made it easier for folks who are disproportionately likely to face burdens to make it through the application. And then the last thing on this slide is improving communication, outreach, and enrollment assistance, things very near and dear to my heart. Health insurance is complicated enough for everyone. So we know that using clear and easy to understand communication is good for everyone, all of us included. And this can, for Medicaid and Marketplace coverage, this can help increase the rate of returned paperwork when we're clear about what we're asking. And that also means, in addition to plain language, ensuring that the information is available in someone's preferred language or languages, that forms are translated, and that interpreters are available to provide in-person assistance. It also means using multiple forms of communication to reach people. We know that multimodal communication is the key to getting your message across. So that means using mail, but also email, text, phone calls, and in-person communication whenever possible. Let's move to the next slide. I'll just touch on an example here. Louisiana has deployed a one-way text messaging reminder system, and I'm just going to anglicize it and say la message, but I'm sure there's a better way to say it with a French accent. But what this project does is, or what this effort does, is sends text to people, and it pings them 4 weeks, 2 weeks, and 1 week before the person's Medicaid renewal deadline, and provides them a link and a phone number so they can start the process, ask questions, etc. It's simple stuff. It's not super technologically slick, but it's effective. And one of the principles of this particular project, which was led by Code for America, is to use trauma-informed language, which means they intentionally provide the information in a calm, stress-free way. They neutrally tell people what will happen, and they let the person make the best decision for themselves, instead of being alarmist and unnecessarily causing anxiety or fear around what's going on with their coverage and their benefits. And the last part of the sort of, and we'll go back, sorry, we'll go back 2 slides to my 4 things. Thanks, Farah. The last thing is really investing in outreach and enrollment assistance. This is always important, but it's really important for this coming year. It's necessary to help people complete the application and renewal process. And a big part of that is making sure you have strong connections with the in-person assisters in your community, the navigators, the assisters at community health centers, that you understand what they're doing, they know who you are, and that you're all working hand in glove. And we'll talk more about that in a minute. So now let's go to slide 24. We'll jump ahead. Thanks, thank you. So we've talked about the when, which is 2023, and the what, the list of strategies we just walked through, but now we need to talk about the how. What can you all do, be planning to do to push for the smoothest unwinding process possible by reducing and eliminating administrative burdens? So number one, know your state's plan. What has your state made available or have you otherwise been able to get your hands on? When will they be reaching out to people? How many notifications will they send before someone loses coverage? Understanding is the first piece of the puzzle. Next, you want to understand what is the process in your state? What does the renewal process look like? What are the specific steps people have to take to update their information, to get a redetermination, to keep coverage? And you might want to consider working with an assister in your community to view the steps of like the online process and understand how it's supposed to work so that you can work together to identify any glitches or ways to improve it. Next, you want to create feedback loops. And I think and hope most of you are doing this already. But what mechanisms do you have in place to collect the insights from the field about how things are going and the areas for course correction along the way? And then who are your contacts in the state agency or the governor's office or even the state legislature that you can reach to share feedback, to share your data, and to push for the changes that you are identifying? And hand in glove with that is tracking the data. What systems or relationships do you have in place to monitor how many people are successfully enrolling, how many people are being procedurally denied, how many people are being transferred to the marketplace, and what's the success rate look like for those folks? What proportion of cases require additional verification? What are call center wait times? I mean, you can just come up with questions endlessly, but they are all interesting pieces of the puzzle that you can use to make things better. And the last piece that I think is critically important is for any and all of these questions, thinking about what kinds of demographic information is available, or can you push the state to make available when it comes to the race and ethnicity of people being affected, age, location in the state, all of that. We've got a great paper that Suzanne wrote on the Emmy website that walks you through how to ask the right data questions. So highly recommend that. And remember, data don't have to just be numbers. Qualitative data are also a really powerful tool. So the last couple of things here, we want to document problems. That's again where the relationships with assisters in your state are going to be really important. Where are people getting tripped up? Are they getting their notices? Are the notices clear or confusing? How long does someone have to wait to get assistance on the phone? Are people submitting documents and still not being successfully renewed? What's happening to people when they lose coverage? And how are those transfers to the marketplace going? And then finally, help spread the word. And this applies both to the ongoing work to keep enrollees up to date on what they need to do so they don't lose coverage. And it will be a pivot from the update your information message we've been drumbeating on for the last year or so to new messages to enrollees to help them understand what steps they need to take in your state. And then you also want to be helping spread the word to your state agency to encourage them to do the right thing. So a couple directions to go with that. Okay, next slide. So to close us out here, just a reminder that although the spotlight is really on next year and the stakes are very high and that is appropriately where our energies need to be focused, this is not just important for next year. Over the long term, advocates also need to be keeping up a drumbeat around the importance of administrative simplification. There is always room for improvement, and making those improvements is critical for advancing racial equity. So continuing to push for administrative simplification should be a standing feature of Medicaid advocacy in every state. With that, I think we're going to turn it to Q&A. So if you haven't put some questions in the Q&A, please feel free to do so now.
Wonderful. Thank you so much, everybody. That was tons of great information. Yes, as Jenny said, please put some Q&A, examples from your state or any feedback into the Q&A section. We'll be happy to address it. While we're waiting for some more of those to come in, I just wanted to kind of pose one around the strategy around this issue. One of the things that we sometimes find when we talk to recipients is an expectation or an acceptance of administrative burden in this process. And I think that is largely held by society that, well, if people want these programs, they have to prove they're eligible. And, you know, that's just something that they have to go through if they want free money or free healthcare. How can we change that narrative? You know, especially looking to next year and what's going to happen, and the fact that wait times and procedural denials and stuff are likely to be excessive. How can we make sure that people stop accepting that as just part of the system and part of the problem, and are as outraged as they should be?
I can take a stab at offering my thoughts on that, Jen. I think it's tough, and I think we hear this from state advocates that kind of just the stigma, and as we cover kind of the history that's tied to Medicaid, makes this kind of tough to break out of. In my mind, I think it's a little bit different talking about reducing administrative burdens versus other things around Medicaid in terms of increasing access. So I think it's different to talk about administrative burdens versus increasing eligibility thresholds, right? I think the eligibility threshold question, that really centers on that whole concept of who's deserving, who's not. In theory, once the state has set eligibility criteria, they've already defined who they think is worthy or deserving and who's not. And so then I think it's really a conversation of, okay, we've said, this is the criteria. If you meet this criteria, you are eligible, you should be able to enroll. And I think it's, personally, I think it's building on that message of, if you are eligible based on the criteria our state has defined, we should not be putting up unnecessary red tape and burdens to access those programs. I know that's easier said than done, but I do think sometimes advocates tend to conflate the two conversations around who is eligible, who should be eligible, versus what is the process when somebody is eligible.
That's a really helpful distinction. So, you know, thinking about the coverage gap states, some people who lose coverage during unwinding will be ineligible for Medicaid. And that's wrong, that's a problem, but that's more of a policy level distinction. But looking at that ASFE report, I think what's so striking is that they've identified the large proportion of people who lose coverage, but are still eligible. So even in states that are maybe more hospital to expanded limits, in theory, they should say, okay, these folks, we've decided they're eligible. Why aren't they enrolled? That's really helpful. Another question is, a lot of the discussion today has been around the MAGI population and the Affordable Care Act and some of those changes that were brought about. So thinking about the non-MAGI population for a minute, the age, blind, and disabled, what are some of the opportunities there, and how can we kind of expand some of these principles of streamlining to that population as well?
Yeah, I can take that one. So I think it's important for us to highlight the non-MAGI population here because of a few reasons. So the non-MAGI population is comprised largely of folks who are seniors or folks with disabilities. This is an often stable population, right? Like their, incomes typically don't fluctuate as much. Their eligibility, criteria are typically pretty stable. So they should have a pretty easy time staying enrolled in the program that they're eligible for. But oftentimes that's not the case. A lot of the sort of flexibilities that were granted to MAGI folks through the implementation of the Affordable Care Act didn't necessarily translate to the non-MAGI population. So those are things ranging from not being able to, conduct a renewal on someone more frequently than every 12 months, use of pre-populated renewal forms, use of electronic data and using it to its maximal, use possible. So in the case of non-MAGI folks, that's using their AVS. And so, for a population that's pretty stable, they often will also have to experience administrative burdens because of these flexibilities that have not really been utilized to their full potential. And so the good thing is that there is an opportunity for that to be changed. The recent notice of proposed rulemaking that was released around eligibility and enrollment and will potentially be implemented in maybe about a year or so, really highlights the barriers that non-MAGI folks experience through the enrollment and renewal process and sort of seeks to very explicitly codify a lot of the same flexibilities that MAGI folks have had in theory, but also being able to use those for the non-MAGI population. So that's something exciting that we're looking at very closely and really hope to see some improvements there.
Just one clarifying question. So the proposed rule will mandate some of these things, but can't states
Yes.
implement them right now?
Yes, they can still implement them. So that's an important distinction too, is that I think based on the way the rules are currently written, like states can do that, but oftentimes choose not to for whatever reason. But they still could right now. And so obviously with unwinding happening in 2023, states can really get ahead of a lot of these administrative burdens and sort of the work that's going to be ahead of themselves, not just for enrollees, but for state agencies, and implement a lot of these streamlining policies that they already have in place for MAGI folks, for the non-MAGI population as well. And that'll help both enrollees and state agencies in the long run.
Great. And one thing people are often confused about is ex parte renewals. That is currently required for the non-MAGI population. People think it's not, but it is in the regulations and has been for many years, even though some states aren't following it. Great. So next question. I think this is kind of geared towards Jenny. Do you have any recommendations on outreach strategies community-based organizations could use to get the word out when the PHE ends? Strategies to ensure they reach harder to serve communities and community members.
Yeah, sure. Thanks for that question. So we haven't, done message testing and that kind of thing, which other groups in this space certainly have, and we have those resources to share with you. But the things that I would say are maybe a little bit obvious, but a multi-pronged strategy is going to be really important. Connecting with groups that serve low-income folks outside of the health space is going to be really important. And you can start, if you haven't already, building the relationships and connective tissue with those organizations now. That might be things like food banks, that could be homelessness service providers, that could be schools. There's a lot of touch points in the community that you need and that we need on our side as allies working through this process. I'm going to go ahead and put in the chat another document that we created, not specifically as part of the Emmy project, but we all work together here on lots of different projects. And this was for our Beyond the Basics project that works specifically with enrollment assisters. But what is designed to do is explain what unwinding is for non-health folks. So not even for assisters, for these other community partners that haven't been eating and breathing and living this stuff for the last 1 year plus, explaining what it is, what they need to do, how they can help. And that is available in 8 languages. So you can use it with folks who are serving a diverse community. And then one other thing that I have heard somewhat anecdotally, but in multiple places, is to think carefully about the messaging and to not talk about the public health emergency ending, and just to be careful about that language. Because when people hear public health emergency, they get a little triggered. It's not always the best language to help people focus on what's happening. So just talking about the facts, your Medicaid coverage may be renewed soon and you're going to have to take steps, and not tying that to the broader sort of COVID world may be a way to help get the message through and not trigger unrelated reactions. So I'll go ahead and put that chat or that link in the chat now.
Great, thanks so much. And thinking a little bit more about that kind of strategy component, I wonder what the opportunities are to leverage what has happened during the continuous coverage requirement. I mean, it's been kind of an interesting experiment in a somewhat zero administrative burden environment, especially for those who are on Medicaid already. There haven't been data checks and renewals. I mean, some states have done them, but you don't lose coverage if you don't respond to it. So it's interesting to think about how we can use that as an example of what the world could be like. I think it's really interesting that like even after in like April, May of 2020, after COVID hit, a number of states found their application volume going down. Despite the massive economic chaos and job loss and everything, there wasn't churn. People weren't losing coverage and having to reapply. So any other thoughts on how to tie these administrative burdens to the worker crisis? We know so many states are down tremendously and missing so many staff. So how can we, use that and leverage that to try to get some of these streamlining things in place?
Yeah, I think you kind of started to touch on it, and I kind of mentioned this too, but like we're focusing here mostly on administrative burdens and how they impact folks who are enrolled in Medicaid or trying to access Medicaid. But administrative burdens also do impact state agencies, right? Like there are administrative costs to be able to have to sort of uphold a lot of these really burdensome requirements that are often unnecessary. And so these tools and strategies for streamlining can help enrollees, but they can also help state agency workers. And so when we're looking at the unwinding context, For example, I think every state agency across the country is short-staffed right now in their agency, and they really are going to be strapped for resources. And this is before unwinding actually begins. So we're expecting states to be extremely, under capacity during the unwinding process. So, doing things like reducing, increasing the rates of ex parte renewals and reducing paperwork requests and using electronic data sources when possible. These are all things that can actually free up caseworker time and allow them to be able to answer other inquiries and do things that actually require that sort of like in-person touch. So a lot of these things are actually going to benefit not just the enrollee, but also the state agency worker. And I don't know if Suzanne, you had anything to add.
I agree with everything Farah said. The one thing I would add is I think that both having the continuous coverage provision in place for as long as we've had it, what we expect to see when unwinding happens, I think is a good time for both advocates and states to take a step back and really evaluate what the renewal process looks like and what they're doing, because that's what they've always done, or that used to be a requirement, but it's not anymore, or there's some other reason they're doing something versus what they actually need to do in order to meet federal requirements. And we find that in a lot of places, states are doing a much more than they need to, which is creating some of those burdens. So I think it's like Jen said, staff, we know there's a ton of staff openings across states for caseworkers and eligibility workers. And it's going to be a tremendous burden on states when unwinding happens. And so thinking about, qualifications from their end, why we're doing some things, and what were the results of some of these provisions during the continuous coverage provision that we can carry on, because we learned after all that it didn't really impact eligibility like some people may have thought it would have.
That's helpful. I think the idea is there they set of streamlining things, and you look at your state environment and what is the administration most receptive to. You can frame it as far as clients and healthcare access. You can frame it as, reducing work for workers and helping to manage a depletion of the caseload. You can frame it, as I talked about today, in terms of racial equity, health equity. There's modernization. There's a lot of different ways. So think about whatever kind of resonates in your state, and many of these streamlining recommendations can kind of be couched under whatever framework folks are most interested in. So last question, we have a handful of states that have new governors that will have new folks coming on board. So in those states, what are your recommendations for how they might kind of approach this conversation about streamlining, about race equity, about unwinding with the new administration?
So great question. I think it will vary greatly from state to state, right? Thinking about what that new governor may be like, what their priorities are. I think it's always important to go back to what platform they ran on, whether that was, supporting families, whether it was something specifically related to healthcare, whether it was strengthening the economy. I think anything really that is in a platform, we can somehow tie back to making sure people can maintain their Medicaid coverage if they're eligible, right? We know that it's good for the economy. We know it's good for people. We know it's good for families. If you have questions, feel free to reach out. I'm sure we can find a way to tie any platform of your new governor back to Medicaid, without a doubt.
All right, and Suzanne has issued a challenge. Please help us figure out how to do that and see if you can stump us. But thank you all so much for joining us. Thank you to Farah, Suzanne, and Jenny for that great presentation. And please be in touch. On these next couple of slides, we have a couple more resources. This is the paper that this presentation was based on. Link to that, as well as the Emmy website, which has a lot of material and information across a variety of subjects, as well as an opportunity to sign up for our Emmy newsletter, where we send out information about webinars, papers, and other relevant resources. And here's a set of papers and other websites and information relative to streamlining the Medicaid process, as well as some things around the race equity and how to frame these pieces. So with that, thank you so much. Here's our contact information. Don't hesitate to reach out if we can help you further. Have a great afternoon, everybody. Thank you.